This is one of those neglected cataracts due to these COVID times. So initially on presentation, I'd already operated his other eye, and on presentation he came with this mature intumescent cataract. So initially I'm going ahead with my incisions, putting in the trypan blue, put in some HPMC, and I have already planned to do a double rexus. So I am starting off trying to do a smallish type of rex. It's already tending to run away. Very tentatively with my bent 26 gauge needle, I'm trying to control this. So I just put in some more HPMC and complete with my Uthrata forceps, as the control is a bit better with the Uthrata. As you can see, even here there is a bit of a struggle. Did get in a small, not perfectly circular rexus. So I want to aspirate this cortex, especially the peripheral, and break this peripheral block, and look what has happened. So I keep on persisting. I'm trying to rotate the nucleus at the same time, and probably a mistake, and look there, it has already extended, and you have the Argentinian flag sign. So I just put in some HPMC, make a nick on the lower part of that limb with a Vanna scissors, put in some more HPMC, and I'm going to now fashion a crude rexus with my Uthrata forceps. Since I've already aspirated some of the cortex, this is easily done. Making sure I have got an adequate rexus. And that's done. I then take my Simcoe once again, just aspirate some of that free cortex, and you can see the nucleus very well rotating. You have to be a little careful. We do not know if this tear is going to extend. More often than not, they don't, and that's a good thing about these cases. However, I would be more careful if this tear was inferior. Still trying my best to aspirate as much cortex as I can get out. As you can see, the pupil is dilated well enough. I then take a sharp chopper. I don't think this nucleus is that hard. However, you have to be very careful when you are laterally separate. So I am doing a combination of both the wood chopper's technique and a quick chop method. I cannot laterally separate too much for fear of extending that tear. Don't need to also. Just making at least 4-5 segments. I'm at 400 millimeters of vacuum, about and 40 ml flow rate, and also at around 60% phaco power. Of course, I'm not using 60%, but that's my setting. Very, very carefully rotating, watching if anything is going to go amiss suddenly. So this is more of a panic move, bringing it out. There was no reason to do this. I thought, okay, it's safer, brought out. I want some space. I could have easily made a few more segments actually. However, What's done is done. That's it. It's pretty soft, and it's very safe to now take it out. You can see at the pupillary plane, my tip is always turned almost posteriorly. I then go ahead. Usually I go for this part where the tear has occurred last, but that's where most of the cortex is, so I have gone there. Just I thought better to take it out when the whole bag is open rather than having it collapse on you later. So you have to be very careful. Just moving that flap away and taking out the cortex. That's done. There is more which I will come to later. And you can see you have to watch very carefully what is going on. Don't pull on the capsule, but you really need to take out the cortex. This is all superior cortex, and if you leave that, that is going to fall down later and give a lot of problems. So the cortex has to be removed. There's no other go. So you can use your irrigation handpiece to move away the iris tissue for better visualization. I've just switched hands, and see, although it looks so clean, just look at the amount of cortex there is. So you really need to take out all this. And once that's done, I check all around. And I'm good to insert the IOL. Decided to put in a 3-piece foldable, and look what happens. I put in the HPMC, and here I should have gone a little further. Anyway, I started injecting, and look what has happened to that cartridge. It has broken, and now I am struggling to push the lens in, and as I push the lens in, the AC collapses. I will quickly come out. I have no choice, because this is a Hoya, you need both your hands on it. My other hand is not free to push in visco from the other side, so I have to first inject the IOL, then come out and put in visco. Anyway, no harm done. I now have to get in the trailing haptic, and this is how I usually do it. I first bring the lens, the haptic, into the anterior chamber, and then I will take 2 dialers. I don't go at the optic haptic junction. I go beyond that, catch the optic, and tuck the whole thing inside the bag. And that's done. It's very well in the bag. You can see both the flaps over it. To take out the HPMC, I just tap on the lens, and I'm not going to go behind this lens, no way. Just tap on the lens, all the HPMC comes off. Aspirate all the HPMC, put in my intracameral antibiotic, make sure all the wounds are watertight, perform the bounce test as well, and conclude my surgery. Thank you so much for watching.